Hello everyone, my name is Anna Lam. I'm electrophysiologist at Inselspital Bern. First of all, I would like to thank Swiss Society of Cardiology to give us the opportunity to present our work, even during the COVID-19 situation. My abstract is about our first experience with ethanol infusion into the vein of Marshall. The ablation of the mitral isthmus can be challenging. Chemical ablation of this region by ethanol infusion into the vein of Marshall has been proposed to obtain block across the mitral isthmus line. We cannulated the coronary sinus and performed the angiography to find the vein of Marshall. After proximal balloon occlusion, we slowly injected 96% of ethanol into the vein of Marshall. Both before and after the chemical ablation, we generated a 3D voltage map of the left atrium to see the low voltage area after ethanol infusion. Ethanol infusion was performed in 12 selected patients. Most of them were male, about 64 years old, and had a normal ejection fraction. Most of them had the previous ablations within the left atrium, and in 6 patients, ablation of the mitral isthmus was attempted before, but not successful. The indication for ethanol infusion was mostly perimitral flutter, but also for mitral isthmus ablation as part of a persistent AF ablation. And a vein of Marshall-related tachycardia was found in 1 patient. Out of these 12 patients, in 1 patient, there was no vein of Marshall present. And in another patient, the vein of Marshall was too small. The cannulation of the vein of Marshall was successful in 10 patients. In 1 patient, a small vein was dissected during cannulation so that the balloon was not inflated in this patient. Another vein of Marshall with a normal diameter was dissected during cannulation as well, but the dissection disappeared so that the ethanol infusion was even possible in this patient. The chemical ablation blocked the mitral isthmus line in 5 of 9 patients. Additional radiofrequency ablation for mitral isthmus in the remaining 4 patients resulted in mitral isthmus block in all 9 patients. After the procedure, we observed a small pericardial infusion in 2 patients, a mild pericarditis in 1, and groin hematoma in another patient. No additional intervention was needed. In conclusion, chemical ablation of the vein of Marshall is feasible, and acute mitral isthmus block is achieved in the majority of patients with additional RF ablation. And we did not observe any relevant complications during this procedure. Thank you for viewing this presentation. I'm looking forward to meet and discuss with you online on Saturday, the 13th of June from 10:30 to 11. Many greetings from Bern and stay safe.